Hello, ladies and gents. Welcome back to Chapter 21, the Lymphatic and Immune System. This is Part 2B. Okay, so quick recap. In Part 1, we introduced the non-specific immune system, which is part of our innate defenses. So it's the same for everyone. It will react the same every single time. And then in the first part of Part 2, Part 2A, we talked about the fact that within the specific immune system, you have the humoral immunity, which is all about the B cells, and the cellular immunity, which is all about the T cells. We discussed how both the T cells and B cells became immunocompetent. And then towards the end of Part 2A, we took a look at the different T cells that your body produces. So what I want to do in this particular part of the lecture is I want to focus a little bit more on the B cells and producing those antibodies. Alrighty, so please keep in mind that your B cells are not only part of our specific immune system, they're part of the humoral immunity, and the option of it, their choice is also to recognize, react, and to remember when a foreign antigen is presented. Now, one main difference between the T cells and the B cells is that the T cells are actively able to kill off the pathogen, where your B cell is more about tagging it for the structure. So it doesn't actively kill it, but it will tag it, making it harder for the foreign antigen to move around throughout the body, and it will also coordinate with the rest of the immune system to make sure that additional T cells and B cells are recruited over. So on this first part of your slide, you're going to notice that under recognition, it's going to tell you that your B cell receptor will bind with the antigen and it will take it in and it will absorb it. And if it sees that that antigen does not belong to the body, it will take a piece of its epitope and it will place it on its MHC2 protein. Now, the reason I said that statement so slowly is because I wanted you to be able to recognize the fact that I said MHC2, and I wanted you to remember that MHC2 only occur on the cell membranes of antigen-presenting cells. So, surprise, surprise, your B cell is also an example of an antigen-presenting cell. So that means that we now have 4 cells that fall in that category. We have our macrophages, our dendritic cells, our reticular cells, and now we have our B cells. And the B cells make an excellent antigen-presenting cell because they will be able to communicate with the T helper cells, allowing for additional T killer cells or cytotoxic T cells to be recruited over. What your B cells will also do is once they become activated, they will differentiate into plasma cells. And plasma cells is where we get our antibodies from. Once you have your antibodies, you can quote unquote attack. And attacking literally means we're going to tag it for destruction. So we're not destroying it, but we're tagging it and thereby immobilizing the foreign entity. Obviously, along the way, you'll also create a memory. So what you're going to notice is that some of your B cells will differentiate into a memory cell so that they can keep track of which antibody was utilized for whichever foreign entity you're currently fighting off. So here on this illustration, it kind of shows you the process of going from a B cell through a plasma cell through an antibody. So go ahead and start taking a look at the illustration on the left-hand side, and you're going to notice that you have antigen recognition going on. So you have your B cells that are immunocompetent. They're able to distinguish self from non-self. And when they come into contact with the foreign antigen, they will partially start digesting it. And if you go over to part 2, you're going to notice that they'll put it on display in their MHC2 protein, making that B cell an antigen-presenting cell. Notice how the helper T cell is communicating with the MHC2 protein on the B cell, and also notice how they went ahead and they labeled those little purple granules as interleukins, because remember, those are those hormone-like messengers that the white blood cells will use to communicate with each other. So as it's doing its antigen presentation and it's recruiting over more T cells, we also start to see that the B cells will do clonal selection. It will go ahead and amplify its number by making multiple copies of itself. And as it's doing that, some of them will differentiate into plasma cells, which will give us the antibody that's specific to the antigen that the B cell was exposed to. And some of the cells will become memory cells to be used as part of our memory aspect of our immune system. The small insert that is on the right-hand side just shows you a general structure of an antibody, and I just basically want to show you that on the left-hand side where the little red box is and it's highlighting the variable region, that is where you'll have the difference from one antibody to the next. And on the other side where it says antigen binding region, that is where the antibody will interact with the foreign entity to tag it and render it harmless. Now, I inserted this little slide. This comes courtesy from a Pearson book because I kind of wanted to show you the importance of antibodies and why it's important to have that memory aspect of it. And what you can see here is that you have an example of what it means when you have a primary immune response versus a secondary immune response. So go ahead and take a look at the graph, and what you're going to notice is that on day 0, they went ahead and they wrote down that the patient has its first exposure to antigen A. So it's exposed to something that it has never seen before, and your immune system will automatically recognize it and it will start to attack it. But the problem is that you won't really have a lot of help from your specific immune system if this is the first time that you're exposed to that antigen. So what we see happening is that usually there is a slight delay before you have specialized B cells or T cells that will respond to this new foreign antigen. So in the case of the graph, you can see that where it says primary immune response to the antigen only occurs after a delay. So a little bit less than 7 days, you see a little increase in the antibody titer. And what's happening with the patient between days 0 to 5? Well, the patient is sick. They're actively trying to fight off, but they really won't have the best sense of their immune system until the B cells and the T cells kick in. So on this graph, it says that your antibodies that are specifically needed to assist you don't really kick in until you get to about day 5 and 6. And as we see, the patient will hopefully get better, and then the antibody will start to diminish because there's no reaction. There's no foreign antigens for them to react with anymore. So your B cells will keep a memory of the event that occurs. So that if we can take a look at the bottom part again of the graph and we go over to day 28, look what happens over there. It says now the patient gets a second exposure to antigen A and its first exposure to antigen B. Now remember, your patient has seen antigen A before, so the fact that the immune system has seen it, it has a memory of it, look what happens to the titer of the antibody. It shoots up right away, and the patient's immune system has a quick and vicious response to this foreign entity. So the body starts actively attacking antigen A from day 1, or I should say from day 28, because that's where it's re-exposed to it. Antigen B was never seen before, so what we see happening is that the body will have a primary response to antigen B, which means that it will have to wait a few days before it has that antibody available to it. I kind of wanted to put this graph because it kind of shows, well, not kind of, it really shows the importance of having a specific immune system, and also it shows having pre-exposure, what a difference it can make to your overall length of illness. So for instance, when we talk about things like vaccines, what the vaccines are trying to do is they're trying to prime the body and they're trying to give you a head start of that primary immune response. So if you do become exposed to that foreign entity, you don't have to wait your 5 to 6 days. You can go ahead and shoot up within the next day and have a high amount of antibody titer because the body has seen that before. And I think in the time that we're in right now, for instance, with the COVID-19, the coronavirus that's going on, one of the reasons why people are getting so severely ill is because this is the first time that they're exposed to this particular antigen. So your immune system is actively trying to fight it off, but for some of us, this might be the first time that it's become exposed to this specific antigen, which means that we have 5 or 6 days where we are severely ill and we're just waiting for our antibodies to increase to give us a helping hand. This is also one of the reasons why one of the mechanisms that they're looking for in treatment is that they're actively starting to recruit over people who have quote unquote survived the coronavirus. So they were exposed to it, they got sick from it, and now they're testing negative. They're recruiting people over to donate their plasma because their plasma is still filled with the antibodies that were utilized by their own immune system to fight off the COVID-19. And these antibodies can then be replicated or they can be donated. Think about your passive immunity. They can be donated to patients that are right now actively fighting off the disease and might be in a worst case scenario. Now, within your antibodies itself, we have different variations, and as you can see right here, these are the 5 most common antibody classes that you can become exposed to, or I should say that your body will produce. I don't want you to worry about memorizing these in great details. I've highlighted the most important concept for each class. So for instance, for antibody A, IG stands for immunoglobulin, which is antibody. For antibody A, or some people like to say antibody alpha, please know that this is the one that you will find in acute infections. And most of the time it's studied because moms will pass it on in their colostrum, which is their first milk secretion, to their newborn child. Antibody D is found on the surfaces of B cells. Antibody E will usually have an increase in its titer when your body is exposed to parasites, as well as if you have allergies. Usually that particular antibody will be elevated. Antibody G, or gamma, this is the most common antibody that a lot of us have floating around. It's about 75 to 85% of the total antibody circulating. The mom is able to pass this on to the fetus because it can cross the placenta, and your antibody G will usually be involved in chronic infections. Your last one, antibody M, is the antibody we associate with our blood plasma. So this is the one that will cause agglutination if you have a mismatch of blood type between patient and donor. Now, the exact attack of your antibodies, you want to keep in mind that it can't actively kill off the pathogen, it will simply tag it for destruction. So when it comes to the humoral immunity, or B cells immunity, its attack mode is going to fall into 4 categories. The first one is that it can just cause neutralization. Neutralization means that the antibody will block the epitope, or the pathogenic region, on the antigen of the foreign cell, thereby masking its pathogenic ability, and aka neutralizing it. The second part is that it can do a complement fixation. Complement fixation means that the antibodies will interact with your complement proteins, thereby amplifying the immune signal and alerting your other T cells and B cells over. The third one is the one that most of us are familiar with, which is agglutination. Agglutination means clumping. So in this case, what we see is that the antibody will bind to the foreign antigen on multiple sites, and as it does so, it will create a clump, or an agglutination, thereby immobilizing the foreign antigen from being further distributed throughout the body. Now, neutralization, complement fixation, and agglutination, those are your 3 methods. We have 1 more to go. The last one is precipitation. Precipitation is the same concept as agglutination, the fact that you're going to take your antibodies and you're going to bind them on several sites of the foreign antigen and you're going to cause the clumping. The difference is that with precipitation, your antibodies are only reacting to molecules, not to cells. So they're doing a much smaller version of agglutination. So you'll have more like a precipitant that will form, not really a clumping process. In fact, what you can do is you can go ahead and take a look at the illustrations, and on A, you can see the little red blood cells, and you can see our antibodies in green interacting, causing agglutination because they're interacting with actual cells. Whereas in illustration B on the right-hand side, you're going to notice that your antibodies are interacting with little molecules. And because they're interacting with little molecules, they're causing precipitation, not agglutination. Either way, you want to keep in mind that they are tagging and immobilizing the antigen. They're not directly destroying it. The actual destruction can come either from a phagocytotic cell, but more likely it will go ahead and be caused by your cytotoxic T cell, because as we've previously discussed, your B cells are in communication with your T helper cells at all times. Now, is there a case where your immune system sort of like overreacts? And it turns out, yeah, it actually happens quite a bit. It's the whole basis for hypersensitivity or allergy development. So if your immune system too aggressively attacks an antigen, you can often be diagnosed with having allergies. And there's different types of allergies. It all depends on how many cells or their time reaction. So the first one is type 1. This is the acute hypersensitivity. This is the most common that people are exposed to. And within this category, the number 1 allergy is going to be asthma. Asthma is when you have an allergen that basically sets off an immune reaction within the bronchioles and the trachea, thereby causing constriction of the air pathway, causing wheezing or shortness of breath. This is usually accommodated by lots of histamine release, which causes bronchial constriction. So oftentimes you'll go ahead and you'll get yourself an inhaler, and the inhaler will be filled with antihistamine, which will allow the bronchioles to dilate and thereby restoring your airflow. If the histamine levels are not restored quickly, then what we see happening is that this reaction can spread across the entire body. And as it does so, then we move away from asthma and we move into anaphylactic shock. Anaphylactic shock, because it's such a body-wide reaction, the treatment will be on epinephrine, no longer on antihistamine. Epinephrine will have a faster reaction by activating our sympathetic nervous system and restoring our blood flow and our breathing regulations. Type 2 hypersensitivity is when we take a look at the interaction between antibodies G and M. And usually what we see happening here is that the antibodies will indiscriminately bind to the wrong places and they might interfere with some of the cell functions. Myasthenia gravis is probably one of the diseases that's most commonly studied in type 2. It is a immune disease that basically attacks the skeletal muscles, causing the muscles to become fatigued very quickly, and it can be detrimental to the patient. Type 3 of the hypersensitivity is all about the immune complex. This usually will also take a look at the relationship between the antigen and the antibody, but it tends to be more of a widespread reaction. So for instance, if you have a patient that comes in and is diagnosed with lupus, lupus is another autoimmune disease. It basically starts by antibodies attacking healthy tissue. It can affect different parts of the body depending on which antibodies are overreacting. We also have the fact that it can attack some of the glomeruli regions in the kidneys, which can obviously go ahead and alter with the functions of the urinary system. Type 4 hypersensitivity, this one is the delayed one. This one will usually only give a response about 12 to 72 hours after the patient is exposed to the allergen. And we see this, for instance, in things like cosmetics and poison ivy allergens when we were discussing our haptens. If you've ever had a TB skin test done to see if your body has been exposed to tuberculosis, you've actually done a type 4 hypersensitivity. In a TB skin test, what they do is they basically scrape a little piece of the tuberculosis protein and they put it underneath your skin, and then you usually have to wait 24 to 48 hours. If there is a reaction at the site, that means that your body has previously been exposed to TB. If there's not a reaction, that usually means that you have never been exposed to it before. You might have noticed that I've kind of skimmed over the hypersensitivities. I don't really want you to spend too much time over analyzing them because this chapter is so heavy on, the whole lymphatic system and your immune system, with the emphasis on non-specific and specific. So please just kind of read over the slides for the hypersensitivity, and at the bare minimum, definitely know that your type 1 is the most common one. This is the one that we mostly associate with our allergies, and of course that is where you will find your asthma and your anaphylactic shock. Another thing that we should definitely discuss when it comes to the immune system is autoimmune diseases, which I know we've brought up during several slides already. Your autoimmune disease basically means that you have your T cells and your B cells that basically make a mistake and they start attacking your own healthy cells. So oftentimes it will be described as a failure of self-tolerance. And this can be due to what they call cross-reactivity, meaning that the foreign antigen is very similar in structure as to a cell that you normally have in your body. A lot of scientists believe that this might be happening in patients with type 1 diabetes, that they are exposed to a virus that looks very similar to the pancreatic islet cells. And as the T cells and the B cells actively attack the foreign entity, they also turn off and start destroying your pancreatic islet cells. You can also have abnormal exposure of self-antigen. This is when a cell is found in an abnormal location. Probably the best example of that, guys, I'm going to pick on you for this one, is in your testes. You have a blood barrier that shields your sperm cells from the rest of the body. If you ever get injury in the groin region that causes that blood barrier to be disrupted, it can cause your sperm cells to start floating in your body, and you're thinking, well, what's the big deal? I mean, they're my cells. Well, the rest of the body has never seen it before, so they might start attacking your sperm cells due to abnormal exposure of self-antigens. The third option is changes in structure of self-antigen. This is usually what we see if there's a mutation or something such as cancer that develops that changes the antigen of your cell, thereby confusing the T cells and the B cells. As you can imagine, if the B cells respond, then what they will do is they'll produce what we call autoantibodies, antibodies against our own cells. There has also been cases where people are born with severe combined immunodeficiency disease, SCIDS, and that basically means that they're born with the lack of being able to produce T and B cells. And if you're born this way, that means that at least you're extremely vulnerable to opportunistic infections because you're not able to mount a specific immune defense. And probably the best case or the best patient studied for severe combined immunodeficiency disease is the little boy that you see pictured on our illustration right here on the right hand side. This is David Vetter. He is the boy that lived in the plastic bubble. So if you've ever seen that movie, or if you used to watch Seinfeld, there was a reference to a boy that lived in the bubble, a plastic bubble. It's all based on David Vetter. David Vetter was born with SCIDS. He was basically raised in a plastic bubble tent that they built for him that was able to purify the air and keep any and all antigens away from him. He wasn't able to go outside. In fact, when he was around 7 or 8, NASA kind of stepped in and built a specific little suit for him, which is what the picture is all about, that was able to filter the air and protect him so that he can kind of roam around and not be exposed to any and all antigens, because he literally had no protection at all. So how do you go about treating SCIDs if you don't want to live inside of a bubble? Well, it turns out that what we need to do is we need to go ahead and do a bone marrow transplant. The bone marrow transplant is there because at the core, your bone marrow will be the site where you produce your leukocytes. So most of the time there's a mutation within the leukocytes that doesn't allow them to go ahead, within your lymphocytes, which doesn't allow you to produce active T cells and B cells. So what did they decide with David? Well, they decided that they were going to go ahead and do a bone marrow transplant. The donor was going to be his sister. His sister was extensively tested to make sure that there were no pathogens present in her immune system, because as you can imagine, David wouldn't be able to protect himself from them. So after extensive testing, they went ahead with the procedure and they did a bone marrow transplant. And initially, all signs were leading to a successful operation until a few weeks later when David got very sick and died shortly after that. And it turned out that in the sister's bone marrow, there were minute amount of virus that were at such a low scale that modern testing wasn't able to detect them, because her immune system was keeping them at bay, suppressed all the way down, so it wasn't doing any harm. But unfortunately for David, because he had no way of protecting himself from even the minutest amount, it overwhelmed his immune system and unfortunately caused his untimely death. There are also examples of immunodeficiency diseases that can be acquired during our lifetime. Probably the best studied model for that is AIDS, which is caused by the HIV virus. Now, the HIV virus is a RNA-based virus that tricks our helper T cells in engulfing it. So it basically tricks our immune system to do what our immune system is supposed to do. But once it gains access to our internal genome, our DNA, the HIV virus will then use its reverse transcriptase enzymes to basically start copying its genome by using our DNA as a template, thereby increasing its viral load. And as it's increasing its viral load, we can see that the HIV virus can lay dormant for many years, or it can go ahead and increase its load, thereby allowing the patient to develop all the symptoms associated with AIDS. Now, initially what we see happening is that the patient can be diagnosed either as just being HIV positive or having AIDS. And the distinction between that will be how severely the disease has progressed. So, for instance, over here on your slide, I wrote down for you some of the early symptoms are more like flu-like chills and fever. And then what we see happening, the patient will start progressing to fatigue, headaches, extreme weight loss. And overall, this has to do with the fact that their T helper cell counts starts diminishing, and it just keeps getting lower and lower. So what we see happening is that a normal T helper count should be between 600 to 1200 cells per microliter of blood, but someone who has full-blown AIDS, their TH cells only are composed of about 200 cells per microliters. And because of this very low number, it means that their immune system is severely compromised to the point where opportunistic infections can just overwhelm the immune systems. So something as a simple cough or a simple cold can lead to full-blown pneumonia, and unfortunately it could be detrimental to the patient. The majority of AIDS patients do not die from the disease or from the HIV virus. They die from an opportunistic infection that gets a hold and overwhelms their immune system. The picture of the man inserted is showing Kaposi sarcoma. This is a specific cancer that starts in the endothelium cells of your blood vessels. And the reason it's highlighted in this particular section is because this form of cancer is only seen when your immune system is severely compromised, which is usually what's associated with AIDS patients. There has been a lot of research that has gone into the transmission as well as the treatment of HIV, and on the screen is just some of the basic information. As you can see, HIV is transmitted through blood, semen, vaginal secretion, breast milk, and across the placenta. The most common means of transmission are through sexual intercourse, sharing of contaminated blood products, and needles. We do know that HIV is not transmitted through casual contact, so holding someone's hand, giving them a hug. That will absolutely not cause the disease to hop from one patient to the next. And we also know that a lot of ways are out there to be safe when we play around, but one of them is definitely the use of a condom. It provides an excellent protection form for the transmission of HIV. Currently, there are many treatment strategies that are out there. The majority of them will try to prevent the CD4 protein on your TH cells from binding to the HIV virus. And by preventing the binding of the CD4 cells, which is a little receptor, it makes it harder for the virus to infect the host cell. And if it can't infect the host cell, then the virus starts to die off. We also have a medication on the market that is called ACT. This one's been on there for quite a bit. It inhibits the reverse transcriptase, so it makes it more difficult for the RNA virus to replicate itself. We also see that there are protease inhibitors. These are all done in an effort to limit the amount of replication that the virus can do. And usually what we see happening is that the patient will be placed on a cocktail, a combination of different drugs. Ultimately, the goal is to keep the viral load as low as possible and keep your TH helper cells as high as possible so that the immune system is healthy and able to fight off any and all foreign pathogens. There has been lots of breakthrough been made in the research field of HIV and AIDS, and with correct treatment, they are able to get the HIV virus to such a low concentration that it's actually undetectable in most of our current tests, which means that it's also very unlikely that you're able to transmit it. Obviously, you need to maintain healthy lifestyle practices, regardless of if you have low or high HIV status. It's always good to be nice and safe and wrap it up, right? All right, guys, that is the end of chapter 21 on the immune system, and I look forward to seeing you in the discussions and getting your emails. All right, we'll talk soon. Bye.